Welcome back to the Deep Dive. I'm your host, and today we're walking straight into a quiet storm. It's the kind of storm that happens behind closed doors, in hospital waiting rooms, at pharmacy counters all across the country. We are taking a look at the pulse of a nation, specifically India's health landscape, as we step into the fiscal year 2025-26.
It's good to be here.
Mm-hmm.
And you're absolutely right to call it a storm. Health in India it's arguably the most complex infrastructure challenge on the planet right now. I mean, you're looking at a system trying to serve 1.4 billion people, and the resources, frankly, just haven't caught up to the demand.
And to get us started, I want to throw a paradox at you. It's something I've been wrestling with since I started reading the reports for today. On the one hand, India is this global medical destination. We hear about medical tourism. We have these gleaming, Apollo and Fortis hospitals that look like five-star hotels. And of course, we've got the title Pharmacy of the World.
That's the image, yes.
Well,
that's the image we project to the world.
But then you look at the data. I'm looking at the National Family Health Survey, the latest systematic reviews, and I see a completely different reality. I see a reality where a single hospital visit can still push an average, even a middle-class family, straight into poverty. It really feels like we're living in two different countries at the same time.
That is the central tension of Indian healthcare. It really is. It's a story of these incredible victories. I mean, think about it. We crushed polio. We've stabilized population growth. But those victories are clashing, sometimes violently, with new, very expensive enemies. We're talking lifestyle diseases. We're talking about an aging population. We're in a transition phase. And transitions are always messy, and they're almost always expensive.
Right. So for this deep dive, we're stripping away all the political rhetoric. I don't care about the speeches. I want to see the receipts. We've got the PRS legislative research analysis of the 2025-26 demand for grants, which is, basically the government's checkbook. We have the NFHS 5 data, and we have a really fascinating and honestly a slightly terrifying systematic review from 2025 on something called out-of-pocket expenditure,
which we'll just call OPE for short.
Yeah.
And that review is absolutely crucial, because it tells us what's happening in the households, not just what's happening in Parliament. It's the difference between a number being allocated and a rupee actually being spent.
Exactly. Our mission today is to look beyond those budget headlines. We want to understand how people are getting treated, what is making them sick in 2025, and maybe most importantly, who is actually paying for it all.
And just to set the stage here, it's so important for you to understand that healthcare isn't just about doctors and nurses. It's not. It's about the entire financial architecture of a country. We're seeing this massive shift from, let's call it survival mode, dealing with infectious bugs, to management mode, dealing with chronic conditions that last a lifetime. And that shift, well, it changes everything about how money needs to be spent.
Okay, let's unpack this. Let's start right there with the money, segment 1, the money trail.
Follow the money, always.
So I'm looking at the 2025-26 budget snapshot from the PRS analysis. The Ministry of Health and Family Welfare has been allocated RS 99,859 crore.
Just shy of a lakh crore. It's a big headline number.
Right, and that's an 11% rise over the previous year's revised estimates. Now, I have to be honest with you. When I see a number like 99,000 crore, my brain kind of short circuits. It just sounds like an astronomical amount of money. But you're the economist here. Is it actually a lot?
It sounds huge in absolute terms, of course. None of us deal with numbers that have that many zeros in our daily lives. But in economics, everything is relative. It has to be. You have to compare it to the size of the house you're trying to maintain. In this case, the entire Indian economy.
So as a percentage of GDP?
Exactly. And that's where the picture changes quite dramatically. You see, the National Health Policy, way back in 2017, it set a very specific target. It was a promise, really. It said that by 2025, which is where we are right now, the government, so that's the center and states combined, should be spending 2.5% of the GDP on health.
Are it there?
No, not even close. We're currently hovering at around 1.8% of GDP.
So we missed the target by a lot.
We missed it significantly. And just to understand how low that is, we need to look at a global comparison. If you look at other large developing economies, take Brazil, for example, they spend about 7% of their general government expenditure on health. China, it's about 10%.
And where is India in that list?
India is trailing significantly. So even with this 11% increase, which sounds good on paper, we are still very much playing catch-up.
I want to pause on that 1.8% number for a second. Why is it so hard to move that needle? I mean, is it just a matter of the government not wanting to spend the money?
Well, it's not just about will. It's also about the plumbing of the financial system. It's crucial to remember that in India, health is primarily a state subject. The center in New Delhi can allocate the funds, but it's the states that have to actually spend them. And what we see in the PRS report, and frankly every year, is this chronic issue of underutilization.
Meaning the money is sitting there, but it isn't getting spent.
Exactly. It's like having a gift card that expires before you can use it. The center releases funds, but the states often lack the administrative capacity to deploy those funds efficiently before the fiscal year ends. Or, and this is a huge problem, they fail to provide their matching share, because most central schemes require the state to chip in, say, 40%. So if the state is broke, they can't afford to take the central money. So that 1.8% reflects not just a lack of allocation, but a real failure of absorption.
That is a critical distinction. It means the whole system is clogged. But here's the thing. If the government, state, or center isn't paying for healthcare, the sickness doesn't just vanish. Someone has to pay.
And that someone else is the patient. And this brings us to what I think is the most dangerous acronym in Indian healthcare, OPE, out-of-pocket expenditure.
This was the part of the research that honestly shocked me. I think most of us assume that between government hospitals and, maybe some private insurance, we're covered, but the data says something very different. Define OPE for us really clearly.
OPE is exactly what it sounds like. It is the money you pay directly from your wallet, your bank account, at the point of care. It's the cash you hand over for the medicines, for the doctor's consultation, for the blood test, for the hospital bed. It's money that is not covered by any insurance and isn't subsidized by the government. It is immediate liquidity-draining cash.
What's the number? What percentage are we talking about?
The latest data we have indicates OPE is at 47.1% of the total health expenditure in the country.
Wow. Hold on. So nearly half, literally half of all the money spent on health in India comes directly from the pockets of the people getting sick.
Yes. Now, to be fair, we do have to acknowledge the progress. Back in 2004-05, that number was almost 69%. So getting it down to 47% is a massive improvement, and that's largely driven by government schemes. But globally, it is still dangerously high. The WHO, for instance, considers anything above 15 to 20% to be major financial risk to households. We are more than double that.
Why is 47% so dangerous? I mean, we pay for food out of pocket, we pay for clothes. What makes health so different?
Because you can choose not to buy a new shirt. You can put that off. You cannot choose to not treat a heart attack. Health expenditure is what we call inelastic. It's non-negotiable. And because it's often unplanned and often very large, it triggers what economists call the catastrophic threshold.
The catastrophic threshold? That sounds pretty ominous.
It is. It's the precise point where paying for healthcare pushes a household below the poverty line. Or, if they're already poor, it pushes them into destitution. We call it distress financing.
The systematic review had some truly heartbreaking details on this. It wasn't just numbers. It was a description of, I guess, survival strategies. It mentioned that lower-income households and rural populations are literally selling their assets to pay for care.
That's right. And we're not just talking about dipping into a savings account here. We're talking about selling the family cow that provides milk for the children, selling the small plot of land that provides the next crop, selling the wife's jewelry. Or, and this is incredibly common, borrowing money from local moneylenders at 30, 40, sometimes 50% interest.
That's a debt trap. You can never get out of that.
It is a generational debt trap. You might cure the disease, but you kill the family's economic future in the process. And this is where the review highlighted something called the fairness paradox, which I found just fascinating.
What's the fairness paradox?
The financing system is actually becoming less fair over time, even as the government spends more. It sounds counterintuitive, right? See, the rich spend more on health in absolute terms. They go to the fancy private hospital, they get the private room. So on paper, that looks like a pro-rich bias in spending. But the poor spend a much, much larger chunk of their disposable income.
Right. A 50,000 rupee bill for a wealthy family is maybe a canceled vacation. For a poor family, it's everything they own. And then some.
Exactly. The marginal utility of that money, as we say, is infinitely higher for the poor. So the burden is what we call regressive. The poor feel it more acutely.
And what are they spending it on? I always assumed it was the big, dramatic stuff, heart bypasses, fixing broken legs from an accident.
That's the common assumption. And I think it's because we all watch medical dramas, so we think healthcare equals surgery. But the data, the real-world data, says otherwise. The single biggest driver of out-of-pocket expenditure is medicines.
The pharmacy bill, not the surgeon's fee.
The pharmacy bill. Especially for outpatient care. Think about it. You go to the doctor because you have a fever or your blood pressure is high. They might charge you 500 rupees for the visit, but then they write a prescription for 2,000 rupees worth of medicine. You have to buy that. Insurance in India, as a rule, covers hospitalization. That's when you are admitted for 24 hours or more. It rarely covers the medicines you take at home.
That is a huge, huge gap. That means every single chronic condition is essentially an out-of-pocket expense for life.
It is. That review noted that 4.4 million households in India faced financial hardship solely due to the cost of medicines. Not the surgery, not the hospital stay, just the pills. This is why the generic medicine stores, the Jan Aushadhi Kendras, are so critical. But their penetration is still nowhere near 100%.
There was one other statistic in that review that I found really morbid, but I think we have to talk about it. The cost of dying.
Yes, this is a very difficult, very sensitive area of health economics because it touches on ethics and emotion. The data shows that inpatient expenditure for deceased patients, so people who eventually died in the hospital, that cost increased by 94% over a decade.
94%. That's double the rate of increase for patients who actually survived and went home.
Exactly. What this tells us is that families are spending massive, massive amounts of money on end-of-life care. They're in the ICU, likely in a private hospital, desperately trying to save a loved one even when the prognosis is very poor.
Well, of course. It's an act of love. You can't put a price on your parents' life. You'll do anything.
Emotionally, you cannot. But economically, the system does. We call it feudal care in economics, which sounds incredibly harsh, I know. But think about the impact. A family spends its entire life savings in the last 10 days of a patriarch's life. He passes away. And the family is left not just with grief, but with total financial ruin. It highlights that the system is often set up to extract maximum revenue at the point of maximum human vulnerability.
That is a heavy thought. It really highlights that healthcare isn't just about getting better. It's about the financial ruin that can come even if you don't.
And this financial pressure is changing and intensifying because the type of sickness we're dealing with is changing. The enemy has changed.
Which is a perfect lead-in to our second segment, the epidemiological shift, or from bugs to lifestyle.
Right. If you look at India 30 or 40 years ago, the main burden of disease was from communicable diseases, infectious diseases, maternal issues, neonatal problems, things like malaria, tuberculosis, cholera, things you catch from the environment or from other people. Now, the burden has overwhelmingly shifted to non-communicable diseases, or NCDs, heart disease, cancer, diabetes, chronic respiratory issues. Just look at this number. In 1990, NCDs caused about 38% of all deaths in India. By 2016, that number jumped to 62%.
That is a massive swing. It's like we've effectively swapped one entire set of problems for another, much more expensive set.
It is a fundamental transformation of the country's health landscape. And connecting this back to the money we were just talking about, treating NCDs is significantly, and I mean significantly, more expensive.
I liked the way you framed this when we were chatting before the show. You said infectious diseases are often a one-time fix.
Generally speaking, yes. If you have a bacterial infection, you take a course of antibiotics for a week. The cost is maybe 500 rupees. If you want to prevent polio, you take a vaccine. The cost is minimal. It's a transaction. You pay, you get treated, and hopefully you're done.
But NCDs are a different story.
A completely different story. NCDs are forever costs. If you are diagnosed with diabetes at the age of 45, you aren't cured. You are managed. You need insulin or other medication every single day. You need daily monitoring strips, regular kidney function tests, annual eye exams. You become a customer of the healthcare system for the next 30 or 40 years.
And that cost just accumulates. Month after month, year after year.
It compounds. The data shows that private hospital treatment for something like cancer or heart disease costs 2 to 4 times more than in public facilities. But since the public facilities are overcrowded and understaffed, as we'll see, people are forced to go private. And the meter just keeps running.
And under all of this, there's a demographic time bomb ticking away, isn't there? We keep hearing about young India, the demographic dividend.
We do, and that dividend has been real. But it's a temporary state of being. The demographic time bomb is the aging of the population. The total fertility rate, or TFR, has dropped to roughly 2.0.
Which is actually below the replacement level of 2.1.
It is. It means the population is stabilizing, which is good, but it also means it's aging. We aren't having enough babies to keep the population pyramid-wide at the bottom forever. By 2036, which is not far away, it's estimated that 1 in every 7 Indians will be over the age of 60.
Wow, that's a lot of elderly people. That's roughly, what, 200 million people?
It is.
Yeah.
And older people get sick more often. They have higher dependency ratios. NITI Aayog itself has noted that 75% of elders face at least one chronic disease.
So we're looking at a future with millions more elderly people, all with diabetes, heart conditions, hypertension. Do we have the doctors for that? Do we have geriatric specialists?
The short answer is no, we really don't. The Indian healthcare system, you have to remember, was built in the 1950s and 60s. It was designed for maternal and child health, for delivering babies and vaccinating kids. It's an excellent system for a very young country. It is not yet pivoting fast enough to treat grandmothers with complex, multi-organ conditions. We lack geriatric specialists, we lack palliative care, we lack long-term care facilities, we lack home care infrastructure.
But the budget did mention something new for seniors, didn't it?
It did. And it is a significant policy shift. The Ayushman Bharat scheme, or PMJAY, is being expanded to cover all citizens aged 70 and above, regardless of their income level. That's an additional 6 crore beneficiaries overnight.
That sounds like it could be a real relief for those families facing the cost of dying that we talked about earlier.
Theoretically, yes. It provides that insurance coverage. It removes the immediate financial barrier at the hospital door. But, and this is the big question that hangs over this entire conversation, insurance is only useful if there's a hospital to go to and a doctor to treat you.
Ah, right. The classic supply and demand problem. You can give everyone in town a ticket to the movies, but if the theater only has 10 seats, you're going to have a riot.
That's a perfect analogy, which brings us right into segment 3, the infrastructure divide. Or, as I like to call it, building castles versus staffing clinics.
This is where the rubber really meets the road. You can allocate all the billions of rupees you want, but if there isn't a qualified doctor in the chair, the patient doesn't get treated. Let's start at the top. The AIMS obsession. It feels like every time I open a newspaper, a new AIMS is being announced in some new city.
It's a huge flagship initiative, the Pradhan Mantri Swasthya Suraksha Yojana. We have 22 new AIMS approved, and the goal is a noble one, to bring that Delhi level of tertiary care out to the provinces.
A noble goal! But how many of them are actually up and running, fully functional?
Fully functional, only 6.
Only 6 out of 22.
The rest are in various stages of completion. But the bigger issue, the real crisis, isn't the brick and mortar. Building a hospital is actually the easy part. You hire a contractor, you pour the concrete. The hard part is the flesh and blood.
Yeah.
The faculty, the human capital.
The doctors, the professors, the top-tier specialists.
Right. And across these AIMS, an average of 36% of faculty positions are vacant. And in some of the newer ones, the numbers are just shocking. The data for AIMS Madurai, for example, showed a 72% vacancy rate.
72%. Wait, paint a picture for me. What does that actually mean? If I walk into AIMS Madurai right now, what do I see?
You see a beautiful, shiny new building. You see state-of-the-art MRI machines, probably still with the plastic wrap on them, but you don't see the senior neurologist to read the scan. You don't see the experienced anesthetist to prep for the surgery. You don't see the full teaching faculty to train the next generation. It's what you might call a Potemkin village of healthcare. It looks like a world-class hospital from the highway, but inside, it's just a waiting room.
That feels almost more cruel than not having a hospital at all. You give people the hope of a building, but then deny them the actual care. Why is the vacancy rate so high?
Well, it's about incentives. Why would a top-tier neurosurgeon who can make crores in private practice in Mumbai or Delhi move to a semi-rural district?
Yeah.
The government salary can't compete. And maybe there are no good schools for their kids, no job opportunities for their spouse, no real social life. The government builds the walls, but it completely ignores the ecosystem that's needed to convince the doctor to live and work inside those walls.
So that's the top tier, the tertiary care. What about the very bottom of the pyramid, the villages, the rural reality?
That's the primary care level.
Yeah.
And this is your first line of defense. This is your subcenters and your primary health centers, the PHCs. And the data here is equally concerning, if not more so. There's a 22% shortfall in subcenters and a 30% shortfall in PHCs nationwide.
And even where the building physically exists, I was reading about this thing you called the furniture problem.
Chuckle softly. Yes, the furniture problem. It sounds absurd, but it is painfully real. The Indian public health standards mandate that a PHC should have at least 4 beds. The national average is actually decent. About 73% of PHCs meet this basic requirement. But if you zoom in on a state like Odisha, only 9% of PHCs have the required beds.
9%. So if you get sick in rural Odisha and go to a clinic,
there's a very good chance you are lying on the floor, or you're just sent home. But the most critical gap, the real bottleneck, is at the next level up, the community health centers, or CHCs. These are supposed to be the referral points, small, 30-bed hospitals for rural areas. And they absolutely need 4 key specialists: a surgeon, a pediatrician, a gynecologist, and a physician.
The Fantastic Four of rural healthcare.
Exactly. Now, can you guess what percentage of CHCs in India actually have all 4 of those specialists present?
Oh boy, I'm scared to guess given the other numbers. Maybe 50%?
17%.
17, only 1 7.
Only 17%. And what's worse is that the trend line is moving in the wrong direction. The shortage of specialists at CHCs has actually jumped from 46% in 2005 to a staggering 80% in 2023.
Hold on, let me process that. We are 80% short of the specialists we need in our rural community centers.
That's what the data says.
So just walk me through the patient experience then. If I'm a pregnant woman in a village with a complication, or my child breaks his arm and it needs surgery, and I go to my local CHC,
There is an 80% chance there is no one there who can treat you. You'll meet a general nurse, maybe a pharmacist, and they'll tell you, we can't handle this here. So what do? You are forced to bypass the entire public system. You get on a bus, you travel for hours to the city, you go to a private hospital and you pay out of pocket. Or you go to a big government hospital in the city which is already overflowing, with people sleeping in the corridors. This infrastructure gap is a direct driver of the poverty we talked about in segment 1.
it's all connected. The empty chair in the rural clinic leads directly to the sold jewelry in the city pawn shop.
Precisely. It's a hydraulic system. If you block the flow at the bottom, the pressure just explodes somewhere else, usually in the patient's wallet.
Okay, let's pivot to a specific demographic that relies so heavily on these very systems. Segment 4, the mixed bag of maternal and child health.
This is an area where India has actually seen some of its biggest, most celebrated successes. But it also has some of the most stubborn and frustrating failures. It's a paradox within the larger paradox.
All right, let's start with the good news. We could all use some good news.
The good news is institutional births. This has been a massive concerted government push for decades. Schemes like Janani Suraksha Yojana, which basically provides cash incentives for women to give birth in a hospital.
Yeah.
And it's worked. The rate has skyrocketed to 88.6%, up from about 79% just a few years ago.
Which means almost 9 out of 10 women are now delivering their babies in a hospital or clinic, not at home with a traditional midwife.
Correct. And because of that, maternal mortality, the MMR, has dropped to 97 per 100,000 live births. That is a significant life-saving achievement. Immunization coverage is also up to about 77%. So we are getting things right.
Okay, so babies are being born in hospitals and they're getting their shots. That's great. But then I read about what the report calls the anemia paradox.
The anemia paradox. This is incredibly frustrating for policymakers and for everyone on the ground. We have these huge schemes like Poshan 2.0. We have a massive distribution system for iron and folic acid tablets. We are throwing money and resources at this problem.
And yet, what's happening?
Anemia is increasing. More than 57% of women and over 67% of young children in India are anemic.
How is that even possible? How can it be increasing if we're handing out free iron tablets? It's a pill. You just swallow it.
It's not just about the pill itself. It's about what we call implementation failure. The data shows that only 44% of pregnant women who received the pills actually took them for the recommended 100 days.
So more than half of them are getting the pills but not taking them. Why?
Well, it's complicated. Sometimes the supply chain breaks down and the pills don't reach the village on time. Sometimes the women get them but don't take them because iron tablets can cause side effects like nausea and constipation, and nobody has counseled them on how to manage that. And sometimes it's about absorption. If your gut health is poor due to parasites or contaminated water, the iron doesn't get absorbed in your body anyway.
And what about the money side of it?
The states are massively underutilizing the funds. The data showed that states, on average, only spent 34% of the funds that were specifically allocated for anemia control.
That feels almost criminal. The money is sitting in a government bank account while children are having their cognitive development stunted.
It's a classic case of administrative inefficiency meeting a complex social problem. And then there's the other side of the maternal health coin, the C-section epidemic.
I saw the numbers on this, and it looked like a massive, glaring discrepancy between public and private hospitals.
It is. In public government-run hospitals, the C-section rate is about 14.3%. That's roughly in line with what the WHO considers medically necessary. Around 10 to 15% of births might require surgery.
And in private hospital,
47.4%.
almost half of all deliveries are surgical.
Yes!
I mean, that can't be medically necessary. That implies a profit motive, doesn't it? A C-section costs a lot more, and it's faster to schedule than waiting for a natural birth.
It strongly suggests a profit motive, or, at the very least, a convenience factor. A natural birth can take 24 hours and happen at 3 a.m. on a Sunday. A C-section takes 45 minutes and can be neatly scheduled for Tuesday afternoon. It really highlights how the private sector, while it's filling a huge gap left by the public sector, operates with a very different set of incentives that are not always in the best interest of the patient's health or their wallet.
And there was one more stat on this that struck me, antenatal care.
Yes, the WHO recommends a minimum of 4 checkup visits before a woman gives birth. In India, only 58% of pregnant women get this. So we're doing a great job of getting them into the hospital for the grand finale, the birth itself, but we're missing the crucial preventative care in the months leading up to it.
We're focusing on the event, not the entire process of care.
Exactly. A classic Indian approach, you might say.
Now, throughout this, we've been talking about India as if it's one single monolithic place, but we both know it isn't. Which brings us to segment 5, the lottery of birth, state, and regional disparities.
Health in India is a state subject. That's the most important thing to remember. And where you are born determines, to a shocking extent, whether you live or die. It really is a lottery.
We have these high-focus states, Uttar Pradesh, Bihar, Madhya Pradesh, Rajasthan. It's often the same list of states when we talk about any development lag.
It is. And here's the funding flaw that I think is so important for people to understand. You would assume that the poorest states, the ones with the worst health outcomes, get the most help from the central government.
Okay.
Right? That's how progressive systems are supposed to work.
Of course. That would be the logical way to level the playing field. You give more help to the person who is drowning.
But the data shows the complete opposite is happening. These states often receive lower per capita grants from the center than better performing richer states like Kerala or Andhra Pradesh.
Wait, run that by me again. Why would that happen? That makes absolutely no sense.
It happens because of the structure of what are called centrally sponsored schemes. They usually require a matching contribution from the state. So for every rupee the center gives, the state has to put in, say, 40 pays of its own money.
Ah, I see where this is going. It's like a buy one, get one free sale at a supermarket.
Exactly. And if you are Bihar and your state budget is already stretched to the breaking point, you can't afford to put up your 40 pays. So you don't get the center's rupee. You lose out on the entire benefit. Meanwhile, a richer state like Tamil Nadu says, no problem, here's our 40 pays, and they successfully grab those federal funds.
So the rich states get richer infrastructure and the poor states fall further and further behind. It's a structural trap they can't get out of.
It's a vicious cycle,
Yeah.
and you see the results in things like personnel density. The WHO recommends a minimum of 44.5 health workers per 10,000 people. Only one state in India meets this.
Kerala.
Only Kerala. Out of all the states and union territories, only Kerala. States like Bihar and Jharkhand have massive, crippling shortages. And because the public system there is so weak, what do people do? They flee to the private sector.
The data point on that was staggering. In a place like Bihar, 80% of people don't use government facilities for their healthcare needs.
80%. Just think about that. The vast majority of the population has completely opted out of the state-run system. And when you ask them why, they cite poor quality of care, 48%, long waiting times, 46%, or simply that there's no government facility nearby, 40%.
So for 4 out of 5 people in Bihar, the government hospital might as well not exist. It's a ghost building.
Essentially, yes. For all practical purposes, they're on their own.
Which brings us to the safety net, or at least the attempt at building one. Segment 6, insurance and the future. Let's talk about Ayushman Bharat, or PMJY.
PMJY, Pradhan Mantri Jan Arogya Yojana. It's the world's largest government-funded healthcare program, and we have to acknowledge its scale and ambition. It provides a 5 lakh rupee coverage per family per year to the bottom 40% of the population.
And the budget for 2025-26 gave it a big boost. Rs 9,406 crore, which is a 24% increase from the previous year.
It's a healthy increase, yes. And as we mentioned earlier, they are expanding it to cover all senior citizens over 70 and, very interestingly, to gig workers.
That gig worker announcement is huge. We're talking about the food delivery guys, the app-based cab drivers, all the platform workers.
It's a critical recognition of how the economy is changing. These are people who don't have a traditional employer-sponsored health plan. Covering them is a massive step forward. But, and with any scheme this large, there is always a but, we have to look at the critiques and the gaps.
Yeah, missing middle.
Exactly. The scheme covers the poor, the bottom 40%. The rich, the top 20 or 30%, can afford their own private insurance. But the missing middle, that chunk of the population in between, has nothing. They are too rich to qualify for PMJAY, but they are far too poor to actually afford a heart attack One bad illness can wipe them out and push them into the poor category.
And the other major issue is what it covers. We just talked about how medicines are the biggest cost driver for families.
Right. And PMJAY, like most insurance in India, covers hospitalization. It does not cover outpatient care. It doesn't cover the daily doctor visits, the insulin, the blood pressure medication. And remember, that is where the bulk of OPE comes from. So PMJAY is designed to stop the catastrophic bleeding from a major surgery, but it doesn't do anything to stop the slow, chronic bleed from managing a long-term disease.
So if I have diabetes, PMJY doesn't help me pay for my daily insulin. It only kicks in when my foot gets gangrene and needs to be amputated.
That is a very harsh way to put it, but in essence, yes. It's designed to cover the amputation. It's not designed to pay for the insulin that could have prevented the amputation in the first place.
That seems incredibly inefficient.
It is. Global evidence suggests that robustly covering primary and outpatient care is actually cheaper in the long run because it prevents these big, expensive surgeries. But it's administratively much harder to do.
And what about the average claim size? I saw that in the report.
The average claim size is only about 11,000 rupees.
That seems really low for a scheme that has a coverage cap of 5 lakhs.
It does. And it suggests that the scheme is mostly being used for smaller, high-volume procedures, things like cataract surgeries, maybe a minor treatment here and there. It often excludes the really high-end complex surgeries because the package rates, that's the price the government agrees to pay the hospital for a procedure, are set too low. A top private hospital will simply refuse to perform a complex heart surgery at the government's prescribed rate.
So you have the insurance card in your pocket, but you might not be able to use it for the big, life-threatening stuff because the hospital says the government's payment doesn't even cover their costs.
Exactly. It's the difference between access on paper and actual access in practice.
Okay, we have covered a massive amount of ground here, from the RIS 99,000 crore budget all the way down to the 17% specialist presence in rural clinics. Let's try to bring this all together in our outro.
If I had to summarize the state of Indian healthcare in 2025-26, I'd go back to the analogy of a body. We have, over the last few decades, built the skeleton. We have the infrastructure schemes, we have the insurance frameworks, we have the policy documents. The bones are there.
But the body lacks muscle, and it lacks blood.
It completely lacks the muscle, the staff, the specialists, the nurses, the ASHA workers, and it lacks blood, the adequate GDP spending. 1.8% just isn't enough to keep a body this large and this complex moving, especially when it's aging so rapidly.
So what does this all mean for you, our listener? What's the takeaway?
The takeaway is that whether you live in a metro city or a small village, the data suggests a very difficult reality. Relying solely on the public system is becoming statistically challenging due to the vacancies and the long waiting times. But the private system is becoming financially perilous due to rising costs and the prevalence of unnecessary procedures like C-sections.
You're caught between a rock and an extremely expensive hard place.
You really are. And the only sustainable way out is a massive, sustained increase in public investment and
We encourage you to look up your own state's health data. The disparities are wild, and knowing where your state stands really does matter.
Absolutely. Informed citizens can force better policy.
That's it for this deep dive into India's health landscape. Thanks for listening.
And stay healthy.
We'll see you next time.